All right. So Dr. Ryan Feldman, who is one of my colleagues and I guess a podcast extraordinaire. He is the one who runs the Poison Lab podcast. It's a kind of a fun Q&A knowledge drop if you guys are interested in it. He is going to speak next on injectables. And Ryan, do you have a little known fact to share with us?
I do. Since we were talking about, I was a little hesitant to share this fact, but since we were talking about sort of extreme health, fitness, and cosmetics, I was going to share that I actually have utilized one of the performance-enhancing drugs that Dr. Stefblug talked about, and that would be creatine, because one of my non-toxicologic hobbies is quite non-competitive powerlifting. And I can I share my screen here?
Yeah.
Okay. Okay. So one of my hobbies is non-competitive powerlifting, and I recently reached sort of an arbitrary goal that some people who are in this hobby shoot for, which is a 5-plate or 500-pound deadlift. But I know I'm talking to toxicologists here, and that means very little to you. So I'm going to put it into terms you can understand, which would be 228 million milligrams, or enough mucomist to provide 150 milligram per kilogram load to 8 blue whales. So I thought that was a fun little anecdote. Okay. And with that, I'm excited to be here, and thank you. I appreciate that I have now a captive audience. I think the West Coast has now woken up and is probably in attendance. And I'm happy to talk about cosmetic injectable toxicity, or when shots go wrong. Today, we're going to review some trends in illegal cosmetic injectable use and try to understand toxicities that arise from those trends. We're going to review the pretty fragile toxicology literature that's out there. It's primarily case reports and case series. But my hope is that we can get a few useful pearls should we ever be consulted about toxicities from these cosmetic injectables. I have nothing to disclose in regards to this presentation, but some disclaimers. There's a limited time, so there's going to be limited information. We're going to do a high-level overview of the illegal cosmetic injectable landscape, which is pretty vast. And then we're going to focus in on complications from body fillers, particularly. And my final disclaimer is that this presentation is short, but the day can be long. So I'm sure I will try to interject some poor attempts at humor throughout the way. So I wanted to start the presentation with why people pursue cosmetic enhancing procedures, but really our next speaker is an expert at this. And I found myself having to cite them when I was reading through their articles. So I'll let them cover the true deep dive, and I'll give you my basic interpretation. People like when they like the way they look, and some people will pursue cosmetic injections to get that look. In fact, in 2020, at the height of a pandemic, we did 22.4 million cosmetic procedures. That's performing a procedure on roughly 1 in every 15 U.S. citizens, or 7% of the U.S. population. And the vast majority of these were minimally invasive cosmetic procedures. Those are things like lasers, peels, cryotherapies. There's actually 15 distinct procedures defined by the American Society of Plastic Surgery, and injectable procedures are the most common. Things like Botox and soft tissue fillers being numbers 1 and 2, and other things like sclerotherapy and injection lipolysis included in there. The high procedural demand coupled with the high cost has unfortunately created some black market conditions. In 2018, the surgeon fee for a buttock implant was about $5,000, but you could go to the black market and get this done for about the 10th of the price by getting a buttock filler. And you'll notice that my background is actually an alleyway. I wanted to just inform you I'm actually presenting live from one of the medical facilities where many of these procedures are performed. Unfortunately, the low cost of these procedures is frequently coupled with high risk when it's done on the black market. It's usually done by people falsely portraying themselves as medical professionals, using inappropriate injection techniques and products with no regulation. This is a recent example, in March of 2021, there's been a lot more, of someone who was arrested at a Botox and Bubbles party. This was a phlebotomist who was claiming to be a physician and was injecting a substance with Chinese labeling on it that we believed to be Botox, and was actually arrested attempting a one-handed injection because he was shipping champagne out of the other hand. So most of us can weigh the pros and cons of looking hot versus having a non-medical intoxicated grifter inject extremely potent toxins into our face. And unsurprisingly, sometimes the pros win, I guess. In fact, they win so often that silicone oil injections have been criminalized in 3 states for the purpose of body augmentation. And Florida had to create a specialized task force called the Unlicensed Medical Activity Unit to track down these people performing risky procedures. There were 661 complaints to this activity unit in 2012, but who knows how many people these false medical professionals operated on. The incidence of illegal procedures is unknown, seeing as it's an illegal activity. It's not usually reported. And even if there's a health complication, we don't usually track whether it was from a medically licensed cosmetic procedure or an illegal one. Unfortunately, there's more than this. If we step outside the world of cosmetics and into the world of fitness and body modification, there's a deep rabbit hole of unique procedures like using site-enhancing oils to increase muscular size, or the practice of bagel heading, which is where you have saline infused into your forehead and somebody puts a depression in the middle to give you a nice everything bagel look. So if you'll come with me into the bagel hole, we'll explore the world of illegal body-enhancing cosmetic injectables. We're going to start with a case. This is Jeremy, and I'm going to use him throughout the presentation to tie some concepts together. Jeremy is a 31-year-old male who presents to the emergency department with abdominal pain. On physical exam, you notice pretty sweet, prominent calves, as well as erythematous lesions on his arms and legs, and costrovertebral tenderness. When you ask him about his calves, he states a year ago he decided this was the year for calves. He read online about an injectable product called Synthol. He read that it had an immediate effect on appearance and didn't carry the health risks of steroids. He's been injecting this into his calves for 1 year. On a laboratory assessment, you notice hypercalcemia and hematuria. So what are these compounds Jeremy is injecting, and could they lead to the symptoms that he has? A quick crash course in illegal injectable cosmetics. Those looking to increase the size of a body part, like the muscles, external genitalia, or hips, will be using a body filler. Those looking to reduce wrinkles might be using neurotoxins like Botox. Looking to reduce fat in a specific area, you might be doing injection lipolysis with emulsifiers like sodium deoxycholate or phosphatidylcholine. Those looking for a darker complexion might be injecting melanocortin receptor agonists like melanotan 1 and 2. Finally, when you look into the world of bodybuilding and performance enhancement, bodybuilders have been known to inject vasodilators prior to a show to increase vascular prominence. And then there's a whole wild world of non-anabolic performance enhancers, such as kinocellin, which is found its way from horse and dog racing as a muscular tonic into the bodybuilding world as a potential performance enhancer, thought to be an ATP protein builder or an ATP donor. And then the protective peptides such as BPC 157 or body protective compound 157, just one of the notable peptides that are beginning to be used. These are frequently hucked by naturopaths as cure-alls. It's sold as a research chemical, and occasionally athletes will use it to get a competitive edge. It is not currently banned by WADA, but it is something they're watching. So I said this is a high-level overview. We don't have time to dive into every topic. Botox would really require its own lecture, so we can't cover that today. Vasodilators are pretty self-explanatory, and the non-anabolic performance enhancers really don't have a strong pedigree of toxicity to dive into yet. So we're going to focus on these three agents. And we're going to start by talking about the skin darkening agents or the melanocortin receptor agonists. To understand why these tanners, injectable tanners, really exist, we need to go to the place where tanning is a way of life, Arizona. I'm sorry, Arizona, but I have friends there, and they say you can cook an egg on your driveway in the summer. So this is just facts. The year was 1980, and there was a search for an agent to prevent melanoma that was being caused by the hot, hot sun. The University of Arizona was working with a compound called alpha melanocyte stimulating hormone. This is normally produced after UV damage to the skin, and it stimulates a receptor called melanocortin receptor 1. This receptor leads to increased pigmentation via eumelanin production, and then you have a negative feedback cycle preventing further UV damage. But alpha melanocyte stimulating hormone also works on a few other receptors, melanocortin receptors, and is involved in appetite regulation and sexual arousal. The University of Arizona created two analogs of alpha melanocyte stimulating hormone, melanotan-1 and melanotan-2. The thought being you can inject somebody with these analogs, they would create eumelanin without needing UV radiation, and you could prevent radiation-induced melanoma. Neither of these analogs became cancer preventative agents. Melanotan-1, or afamelanotide, actually became FDA approved as a drug called Sinise, which is used to reduce UV radiation-induced exacerbations of erythropoietic protoporphyria. And then melanotan-2, which has a cyclic structure, making it more lipophilic and has more CNS penetration and off-target effects. In preclinical trials, they noticed spontaneous erection. And it took a little bit of a left turn from a cancer preventative agent, and they developed an analog called bremelanotide, which is now FDA approved for hypoactive sexual desire disorder. But what happened to melanotan-2? Well, when the public realized there was a compound out there that could reduce your appetite, darken your complexion, and increase your libido, internet sales for illicitly available melanotan-1 and 2 skyrocketed. And unfortunately, internet sales were not the only things that were rising. Yes, case reports of ischemic priapism were also rising due to the melanotan's ability to regulate sexual arousal. Some of these case reports published right in Clinical Toxicology by people who are actually in this audience. There also happens to be a variety of other off-target effects beyond ischemic priapism. It's thought that the priapism and the weight loss are potentially related to a sympathetic mechanism. So there's a sympathetic or sympathomimetic toxidrome that has been reported with overdose of melanotans. Everything from rhabdomyolysis to posterior reversible leukoencephalopathy. And I believe Doctors Nelson, Axe, and Bryant can go into more in depth about that. Another concern would be the melanogenesis of these compounds can lead to carcinogenicity. And there's case reports of new dysplastic moles or old moles progressing to melanoma in people who are using these. So the toxicities that we see in these sun seekers using sunless tanners are ischemic priapism, sympathomimetic toxidromes, and carcinogenicity. But there's limited case reports and more effects may present themselves. Next, I want to talk briefly about the focal fat reducing agents. These are emulsifiers like sodium deoxycholate and phosphatidylcholine. Sodium deoxycholate is actually FDA approved as a drug called Kybella, and it's marketed as the injection that melts your double chin because it's used for submandibular fat. But if you buy 10 times, if you buy it on the internet and inject 10 times more than you should, instead of melting your double chin, you can melt your red blood cells. So there's at least one case report of hemolysis after subcutaneous deoxycholate acid overdose. If you want to know more, check out poster 284 or a publication in the American Journal of Emergency Medicine. Now, Jeremy, he had no pruritic problems. His complexion was pretty pale, and there doesn't seem to be a lot of fat to emulsify on it. He was using a body filler to increase muscular size. Body fillers are anything with a direct volume enhancing effect after injection. They're the number 2 most common soft tissue filler in procedure performed in 2020, And there's over 160 FDA-approved soft tissue fillers, largely classified as absorbable or permanent. Some common absorbables are hyaluronic acid or autologous fat, where you get your fat injected back into other areas. And then permanents are things like hydrogel polymers or dimethylpolysiloxane, also known as silicone oil, which we've been talking about, which is highly controversial due to its propensity to cause some nasty side effects, which we'll talk about. When body fillers are used medically, they're used to reduce wrinkles or increase fullness of atrophied areas. And they're FDA approved for use on the facial features or hands, but sometimes used off-label. When they're used illegally, they're frequently used for much larger areas, such as the buttock, breast, hip, or muscles. And this requires a larger volume of body filler, which can be a direct contributor to the toxicity that develops. If we examine the patterns of illegal body filler use, three distinct groups seem to present themselves. The first would be the large volume muscle fillers. These are usually bodybuilding men trying to increase muscular size. And there's actually been a term coined for this pathologic desire for increased muscle size called big orexia. These people usually have access to the body filler and are injecting small amounts over multiple days. And the body fillers they frequently use are paraffin oil, silicone oil, or there's actually a product just for this called synthol, which is a mix of medium chain triglycerides, benzyl alcohol, and lidocaine to reduce injection site pain. The next group are the large volume body contours. These are usually people looking to aid feminization, so increasing hip, butt, or breast size. And the use pattern here is a little bit different. These are usually someone going to or bringing someone into the home or having a pumping party where they get a bunch of people together and one person comes in and injects everyone. So because they don't have access to the product, more product is injected at one time, which might directly contribute to some more toxicity potentially. And the body filler usually used here is silicone oil, but others are reported. And our final group are the capsule cosmetics. I'm coining this term because these people are injecting the contents of capsules into their face. Usually oil-soluble vitamins like vitamin E, A, and D are aspirated and injected into whatever facial feature they're trying to enhance the size of. And these are either self-injected or there are esthetician clinics that will do this and cause some outbreaks of nasty lipogranulomas, as you can see there. So, what kind of toxicities do we see when people are inappropriately injecting non-medical grade fillers? Well, obviously, injecting non-sterile compounds can lead to infectious complications, but that's self-explanatory. So we are going to focus on arterial and immune complications. The first arterial complication to be concerned about would be silicone embolism. There are tons of media reports of somebody dropping dead in a parking lot after getting a butt injection. And when you take that person to autopsy, you're likely going to find silicone embolism. This is when you get vascular migration of the filler, either due to direct intravascular injection or high perivascular pressures pushing the filler into the vascular system. This leads to microvascular occlusion, accompanied by an inflammatory response that activates both the clotting cascade as well as the potential for hemorrhage. It's very similar to fat emboli syndrome. The incidence of silicone embolism or filler embolism is increasing. There's been at least 64 cases reported in the last 50 years, but almost 50% were reported in roughly the last 15. Common injection sites are the hip, buttock, or breast, but other sites have been implicated like genital, shoulder, and muscle. And if the patient survives the parking lot and makes it to healthcare, their symptoms are primarily going to be respiratory. Hypoxemia and cough are pretty common, and unfortunately, alveolar hemorrhage is present in over 50% of patients in numerous case series. They can have fevers as well, making this difficult to distinguish from infection due to also having frequently bilateral ground glass opacities on X-ray. And then decreased mental status or unresponsiveness can be present in severe disease. In terms of time to symptom onset from injection, with liquid silicone, 95% of published case reports had symptoms occur within 72 hours. There's a small subset where symptoms were a little bit delayed by a week, but some up to 8 months. And this is for liquid silicone. Implants have the potential for delayed toxicity due to their ability to rupture and then cause problems. Treatment, no surprise in toxicology. Supportive care is a mainstay. Oxygen all the way through ECMO. Steroids are frequently used due to the inflammatory component of the disease, and antibiotics are co-prescribed due to the inability to rule out infection in many cases. If the silicone embolism is due to an implant, you can take the implant out, and that is usually helpful. But if it's liquid silicone, it's very difficult to actually extract because it could have migrated, and it's hard to get all of it out. In terms of clinical outcomes, many of these patients advance to acute respiratory distress syndrome. Of the published cases, mortality is somewhere between 20 and 24%, but it takes a steep increase to about 90% if you present with initial decreased mental status, representing pretty severe disease. And if you survive your initial insult and recover, chronic silicone embolism is possible. There's plenty of cases of patients showing up multiple times in a year with similar respiratory complaints after their initial episode. So our evidence-driven takeaways for silicone embolism: symptoms are most likely to occur within 72 hours of injection. 95% of published cases have. Common sites are the buttock, hip, or breast, but other sites are reported. Symptoms are primarily respiratory, but if you show up with altered mental status, that is a bad prognosis. We treat this with supportive care and steroids, and with those treatments, 75 to 80% do seem to recover. Next, I want to talk about some medical complications that our friends using illegal cosmetics are also at risk for. I want to talk for just a minute about filler blindness. This is when you get accidental ophthalmic arterial injection of the filler, and this is common even under medically supervised injections. There's been about 10 cases a year reported for the last 20 years, and it most commonly occurs during autologous fat injection or hyaluronic acid, when they're injected into the glabellar complex, nose, or nasolabial fold. Unfortunately, treatment is pretty bleak. You cannot TPA a filler out of your central retinal artery, so some try vasodilators to dilate the artery or antithrombotics, but nothing has really been shown to restore sight effectively. One notable exception is if the filler blindness is from hyaluronic acid. There's good data to support that retrobulbar hyaluronidase within 90 minutes should be able to restore vision. Finally, we're going to talk about immune complications, such as fibrosis and granulomas. So fibrosis is pretty self-explanatory. You inject a foreign body into an area, chronic inflammation leads to fibrosing of the tissue. This can be local at the injection site, or it can the filler can actually migrate and you can get fibrosis of other organs like the lungs. And sometimes the fibrosis is so bad you get secondary complications like necrosis of your tissue due to the fibrotic tissue impairing blood flow. And this will sometimes necessitate decontamination. Granulomas are a really important complication, estimated to occur in up to 1% of all body filler procedures, even when performed medically. And these are when you develop hardened inflammatory lesions months to years after the procedure. They can be local at the site of injection, or you can have distal spread due to filler migration. Essentially, after you get the filler injected, it has the capacity to migrate through the body, either through lymphatic or hematogenous spread. And then when your immune system recognizes this as not self and tries to initiate an attack, it's actually very bad at chewing up many of these foreign bodies. So it has to bring in friends. Macrophages recruit more macrophages and form foreign body giant cells to try to eat this giant foreign body. And then you also bring in T cells and fibroblasts to wall off this foreign body. And what we end up with are encapsulated fibrous pockets filled with inflammatory cells, or granulomas. There's many different types of granulomas that can develop, but what we most commonly see with our illegal cosmetics, which are like silicone oil or paraffin oil, are lipogranulomas. And these are characterized on their histology by a Swiss cheese pattern due to the presence of oil vacuoles within the inflammatory cells. And then you see multinucleated giant cells surrounding those. Here are two examples of lipogranulomas near a site of injection. Risk factors for granuloma in development include using liquid fillers, like many of our illegal cosmetics, injecting large volumes, like our body contours, and repeated injections, like our large volume muscle fillers. Finally, contaminants that increase immunogenicity are also increase your likelihood of having a granuloma. So let's go back to Jeremy. If you remember him, he showed up with large calf muscles and erythematous lesions on his arms and legs. Well, the calf muscles, we know that was from his synthol injection. The erythematous lesions, I think we now know, are granulomas related to an inflammatory response from his filler migration. And what about the costovertebral tenderness and hypercalcemia? Well, granuloma and hypercalcemia are like bread and butter. The first case of silicone-induced hypercalcemia from granuloma was reported in 1984, and there's been many since then. But how do we go from an inflammatory fibrous lesion to an elevated calcium? Well, if you actually aspirate that fibrous lesion and put it on a culture, you'll find it hyperproduces an enzyme called CYP27B1. That's the same enzyme that your kidney uses to turn inactive vitamin D, or calcidiol, into active vitamin D, calcitriol, which, as we all know, is what increases calcium absorption and reduces secretion. In fact, compared to kidney cells, granulomas produce far more CYP27B1, probably because they're using it for immune signaling and are under the regulatory control of interferon gamma, as opposed to renal culture or renal cells, which are tightly controlled by parathyroid. The incidence of granulomatous hypercalcemia, it's relatively rare, but there's been at least 61 cases in the last 50 years or so. And in terms of their clinical presentation, if patients present with initial hypercalcemia, there's about a 100% chance they're going to have a granuloma, assuming they've been injecting cosmetics. But if they present with just a granuloma, like in the case series by Eldrup et al., where they had 88 patients that had granulomas related to either synthol or paraffin oil injection, only 34% of those patients were hypercalcemic at the time of healthcare contact. And that's probably because the time from injection to develop of hypercalcemia is extremely long. The average time was 8 years in one case series, and it had a range of 1 to 28 years. In terms of the clinical outcomes for these patients, we have limited data, but in one case series of patients presenting to healthcare due to symptomatic hypercalcemia from these foreign body granulomas, 82% developed some form of kidney injury, either from hypercalcemia-induced vasoconstriction of the renal artery or from nephrolithiasis. And 2 of those patients went on to suffer mortality, unfortunately related to renal failure, and 1 required permanent dialysis. If the patient recovers from their initial insult, recurrent hypercalcemia is super common, 45% in one case series. And there's a number of cases of patients showing up 17 times in a year, or as high as 17 times in a year, for recurrent recalcitrant hypercalcemia. Now, this is patients showing up with symptomatic hypercalcemia. In the other case series by Eldrup, patients did not have such severe outcomes, but the hypercalcemia was essentially identified via screening. Okay, so treatment for these patients. It's generally guided towards immunosuppression to turn down the granuloma expression of calcitriol. Systemic corticosteroids like prednisone, following other granuloma protocols, usually 20 milligrams a day for 2 weeks, followed by a taper. And then intralesional granuloma injection can be done if there's a limited amount of them. And there's many case series of using other immunosuppressants. CYP27B1 inhibition is also utilized to reduce calcitriol production with broad-spectrum CYP inhibitors like ketoconazole. And then for our hypercalcemia treatment, fluids, bisphosphonates are standard hypercalcemia treatments. And then calcitonin is sometimes used, but there's questionable utility because the granulomas are not under parathyroid regulation, and calcitonin is a parathyroid sensitizer. But it does get thrown at patients when you're throwing the kitchen sink. Granuloma surgical excision is ideal, especially in patients who have recurrent hypercalcemia, but it's very difficult due to the poorly defined borders of the granuloma. Of the cases that reported attempted surgery, only 4 of 15 were successful. So our evidence-driven takeaways here. For hypercalcemia, if you present with hypercalcemia and you have a history of cosmetic injection, you likely have a granuloma. If you present with just a granuloma, you might not be hypercalcemic yet. Hypercalcemia can be very delayed, up to 28 years, and the complications from it include nephrolithiasis, renal failure, and death. Treatment is immunosuppression, as well as potentially CYP27B1 inhibition, as well as supportive cares for hypercalcemia. And the hypercalcemia recurrence is pretty frequent. So back to Jeremy. His workup, his calves were warm and well perfused, no concern for fibrosis or necrosis. A CT demonstrated nephrolithiasis and an MRI demonstrated numerous granulomas. After they were aspirated and put under histology, they were noted to be lipogranulomas with a Swiss cheese pattern due to the presence of fat vacuoles. And his labs demonstrated normal renal function for him. That's great. Calcitriol was elevated and his parathyroid was depressed. He was treated with fluids, bisphosphonates, and prednisone, counseled to stop injecting things into his body, and follow-up was scheduled to monitor for likely recurrence. In summary, there are a lot of different reasons why people use body fillers, muscular size, feminization, or facial features, and there's many complications from them. Infectious, arterial, and immune. I'm not going to review everything we talked about, but here are some nice little review points. But there's actually a lot of different cosmetic injectables, and each has their own unique toxicities. Some of them we don't really know yet, like the muscular tonics or protective peptides. I think at the end of the day, we can summarize illegal cosmetic injectable use with probably just don't do it. There's many risks associated with either the product or contaminant, and they're high risk for complications due to unqualified personnel using inappropriate administration technique and higher doses than are normally utilized. So I'd like to end with 4 tips from the FDA about what to check before you inject. Never get any type of filler or liquid silicone injected for body contouring or enhancement. Never buy dermal fillers on the internet, as they may be fake, contaminated, or harmful. Never get injectable fillers from unlicensed providers in non-medical settings like hotels or private homes, and always work with a licensed healthcare provider. And with that, I'd love to take any questions that I could at this time. I hopefully did not go over.
Ryan, thank you so much. What a super fascinating presentation, and also incredibly frightening. Makes me never want to get anything ever. In addition to the TV show Botched. So those two together, none. So there was a question in the chat that said, the altered mental status from silicone implants, what's the etiology of that?
There's a couple proposed mechanisms. One is actually neuronal vascular compromise from vascular obstruction from whatever filler you're using. And then the other is potentially, some people will develop symptoms and not seek care right away, so they can have persistent hypoxia. I believe one of those cases was published by a few members of AACT, so they might be able to provide more information as well.
All right. I don't know that there are any other questions. There was a really interesting comment, though, from Dr. Athong in Thailand. And he said that, some white people want tanning, some Asians want skin brightening. But in Thailand, they're injecting a lot of vitamin C and glutathione, which I thought was really interesting. So I think there's probably some regional differences in what people are using and what effect they're trying to achieve. So, all right. Well, thank you very much, Ryan.
Thank you all for your time.
Yeah.